Assalamu alaikum. Welcome to the second lecture of Phacodynamics lecture series. In this lecture, I will stress on some essential concepts about Phacodynamics. Then we will go through each step of phacomulsification and study the needed parameters and how to adjust it. I will be talking about peristaltic pump since it is the most commonly used pump in our OR. We have four parameters to adjust and change the fluidics during the cataract surgery. First is irrigation, second is aspiration, third is the vacuum, and fourth is the ultrasound. So I will be talking about each one separately.
Before we start, we have to understand the foot pedal.
The first step
When
is
we
for
turn the
irrigation.
continuous irrigation off, we have three steps. The first step,
The second step for aspiration when there is no occlusion, and vacuum when there is full occlusion. The third step, we have irrigation, aspiration, vacuum, and ultrasound. When we turn the continuous irrigation on, we will have only two steps. The first step is aspiration and vacuum. Aspiration when there is no occlusion, and vacuum when there is full occlusion. Second step is irrigation, aspiration, vacuum, and ultrasound.
anterior chamber stability is essential to achieve a complete surgery with low risk of complications. The stability based on the balance between inflow and outflow. Wound size and bottle height control the inflow, whereas the aspiration and wound leakage control the outflow. We have to understand that the small wound size, if we create a small wound size, this can decrease irrigation and inflow.
In order to have a stable and formed anterior chamber, inflow should be equal or more than outflow. We have two types of flowability, distal and proximal. From its name, the distal flowability means the flowability of the nucleus when it is far from the phacotip. However, the proximal flowability, it occurs when the nucleus is very close to the phacotip. Now we will study the forces that can affect the movement of the nucleus. So during phacomulsification, we have two forces. Attractive forces, which also called proximal flowability, which attracts the nucleus toward the phacotip. Aspiration and vacuum are the parameters that attract the nucleus toward the phaco handpiece. Whereas the ultrasound, especially longitudinal, is the repulsive force, which push the nucleus away from the phaco handpiece. If the repulsive force is much higher than attractive force, the nucleus will be held. Then, once the surgeon started ultrasound, a nucleus will move away from the phacotip. This phenomena called shuttering, which is due to imbalance between the two forces. So the repulsive is higher than the attractive forces. Let's imagine here that the face is the nucleus, ultrasound is a repulsive force. The head moves away from the handpiece because of this repulsive force, but the aspiration and vacuum bring the nucleus or the face back to the handpiece to be further emulsified. Aspiration controls mainly the flowability, which is the movement of the nucleus toward the phacotip, whereas the vacuum is the one responsible for holding the nucleus. So we have flowability, which is related to the aspiration, and holdability, which is related to the vacuum. I made this animation to demonstrate the difference between flowability and holdability. Flowability is the movement of the nucleus toward the phacotip. As we mentioned earlier, the flowability controlled by aspiration flow rate. So if the aspiration flow rate is low, the nucleus will move slowly toward phaco handpiece. But if the aspiration flow rate is high, then it will move very fast. Holdability is the function of the vacuum, as we mentioned. If the vacuum is high, the nucleus will be held forcefully by the phacotip. And if the vacuum is low, it barely holds the nucleus. This is very important slide. We have to know that the temperature inside the anterior chamber and at the phaco wound is very important. if the temperature is high in the anterior chamber, it will cause endothelial damage, and if it is high also at the wound, it will result in wound burn. During phaco, irrigation and aspiration make cooling current to lower the temperature inside the eye. However, the ultrasound is the main reason to generate heat. So excessive ultrasound can result in heat generation, which in turn result in endothelial damage and wound burn. For aspiration flow rate, vacuum, and ultrasound, we have two modes: linear, or what is called surgeon mode, and fixed panel mode. In surgeon mode, it is linear and can start from 0 or any value presetted by the surgeon. For example, we can set the machine to start the vacuum from 100 instead of starting from 0. On the other hand, in panel mode, it is fixed. For example, if the aspiration flow rate on fixed 30, once we reach step 2, the 30 will be reached immediately. So the maximum presetted aspiration flow rate will start, which is 30 immediately. So we will not start from 10 or 15 or 0. Also in ultrasound, if we set the power on 70% panel mode, a full 70% power will start once we reach step 3. Now I will be talking about irrigation. What is the IOP during phacoemulsification? The bottle height can control the IOP. For example, if we set the bottle height on 80 centimeter, the IOP is almost 60. And if we raise the bottle height to 110, the IOP will reach 80 millimeter mercury during the surgery. So be careful when you choose the bottle height, especially in cases of glaucoma. So we can calculate it roughly by multiplying the bottle height by 0.736. If the bottle height is too much high, it results in two things: overpressurized eye and poor flowability, because it will result in turbulence inside the eye and it will push the nucleus away from the phaco handpiece. So it will work against the aspiration flow rate. And if the bottle is too much low, the eye becomes soft and the AC become unstable with significant surge, and we will talk about the surge later on. When to raise the bottle height? In normal cataract with shallow anterior chamber, to deepen the anterior chamber. 2. When we increase the aspiration and vacuum. So we increase the outflow, so we have to increase the inflow by increasing or raising the bottle height. 3. In case of hemorrhage, so it will work as tamponade. When to lower the bottle height? If there is complication like BCR, zonulopathy, or when we encounter a patient with high myopia, because the chamber is already deep, and some of them, they have also zonulopathy. The second parameter is the aspiration flow rate, and the third is the vacuum. So what is the effect of the irrigation or bottle height on flowability? If we increase the bottle height, which in turn will increase the irrigation, we will have poor flowability and attractability of the nucleus toward the phacotip, because it is excessively higher than the aspiration flow rate. So we have to have a balance between the irrigation and aspiration. Another clinical concept about attractability: if we set the aspiration flow rate on low, for example 10, the attractability will also be low, and the movement of a nucleus toward the handpiece will be very slow, as we mentioned earlier. But if we increase the aspiration flow rate to 35, for example, the nucleus will move very fast toward the phaco handpiece. What is vacuum rise time? It is the time needed for vacuum to reach the maximum level, or how many seconds needed to reach the maximum vacuum. It is controlled by the aspiration flow rate. So aspiration flow rates controls the speed of vacuum to reach the maximum preset level, but the vacuum parameter control the strength of holdability. So the speed is related to the aspiration flow rate, whereas the strength is related to the vacuum level. If aspiration flow rate is low, maximum vacuum needs more time to reach the maximum level. So to reach the perfect holdability, you have to wait a couple of seconds.
But if the aspiration flow rate is high, the vacuum will reach its preset level very fast. So if the surgeon moves the handpiece before reaching good vacuum level, the nucleus will not be held forcefully by the handpiece. So here the vacuum reach the maximum level faster if the aspiration is very high. And on the left side, as you can see, there is poor holdability because the surgeon moves the handpiece very fast before he reach the maximum vacuum level. Also, I made this animation to show you the effect of aspiration flow rate on the vacuum. Here is the vacuum 400, whereas the aspiration flow rate is very low, which is 10. So the nucleus moves very slowly toward the handpiece. But if we increase the aspiration flow rate for 35, it will move very fast. And also here the vacuum rise time. Poor holdability because of low aspiration flow rate, and the time needed to reach maximum vacuum is also very long. When to increase or when to decrease the aspiration flow rate? We need to increase aspiration flow rate when we need better flowability. For example, if we used high bottle height irrigation, or if there is a high repulsive power. Also, we need to increase it when we need faster vacuum rise, or when the temperature is high inside the eye. For example, when we are dealing with the dense cataract, dense mature cataract. On the other hand, we have to decrease the aspiration flow rate and work on what is called slow motion phaco when we are dealing with soft cataract, or when we have a complication like BCR or zonulopathy, lower vacuum setting. And the fourth indication is milking due to fast occlusion. We have two systems during phaco surgeries. One called hydrodynamic balance system, when the fluid is moving inside the eye and the phaco tip is not fully occluded. In this scenario, the vacuum is still on zero. But when the tip is occluded, fully occluded, we call it hydrostatic closed system. In hydrostatic closed system, the pressure inside the eye reach its maximum level and the vacuum start to build up. So as you can see here, only in hydrostatic closed system the vacuum will build up. So if the vacuum is low, the surgeon will face poor holdability and clogging of the phaco handpiece. And if the vacuum is more than what is needed, the post-occlusion surge will be encountered. The vacuum level should be also tailored based on the phaco tip angulation. So this is the formula of the force of holdability, which explain also the relationship between the holdability and the phaco tip angulation. So the higher the angulation is, the more difficult to be occluded, the higher holdability, the sharp edge, and less clogging, higher power. We have to increase the vacuum when we operate on dense cataract or encounter poor holdability and during chopping. But we have to decrease the vacuum during sculpting or when we operate on soft nucleus, and if there is milking due to high holding forces. As we can see, during phacoemulsification for soft cataract, we will decrease the aspiration and the vacuum. We will move now to power. We have different modules or modes when we talk about the ultrasound power. Shuttering is due to high repulsive power in relation to relatively low attractive forces, as we mentioned earlier. So due to off period during pulse and burst mode, because there is off period, we have more time for aspiration flow rate and vacuum to regrasp the nucleus. So if we have shuttering, it's better to use the modes with off period like pulse or burst. Also, the heat production is relatively lower in pulse and burst mode in comparison to continuous mode due to the off time, which allow cooling during this off time.
So less endothelial cell damage and less risk of wound burn when we're working with a mode that includes the off time like burst or pulse. So in the setting of mature cataract, it is better to use, for example, burst mode to allow time for cooling. So we will start with the first step, which is a pre-phaco. Our aim during pre-phaco is to remove the OVD, viscoelastic, at the area of sculpting only, and to remove the epinucleus and cortex as well to maintain a space to start sculpting. The removal of OVD at the area of sculpting is essential in order to avoid a phenomena called OVD caramelization. Caramelization means thickening of the OVD, which occurs due to the use of high power during sculpting. So this high power can change the OVD, and the OVD will become thicker, and it will induce clogging and more heat production, which result in endothelial damage. So the aim of pre-phaco is to remove this OVD with low power. The other aim is the removal of epinucleus and cortex to expose the nucleus. So we will not waste power during sculpting for epinucleus and cortex, which can be removed easily during pre-phaco with much less power. Based on the previously mentioned aims of the pre-phaco, we need aspiration mainly in this step. We don't need much of vacuum, we don't need much of ultrasound. So we will set the aspiration on medium level. Irrigation should be more than aspiration in order to have a stable and formed chamber. We need only low level of vacuum because our aim is not to hold the nucleus. We want only to remove the OVD, epinucleus, and cortex. Do we need a power? Very minimal, because we are not dealing with dense nucleus. We are dealing only with soft OVD, epinucleus, and cortex. Second step is sculpting. So sculpting equals to power. In this step, we need enough power to make a groove. The main aim of sculpting is to make a groove without pushing or moving the nucleus. If the nucleus moves during sculpting, it means the power is insufficient. This movement can result on stress on the zonules, and if there is anterior capsule tear, it will extend further because of this movement. So if you have dense cataract, zonulopathy, or anterior capsule tear, we have to use a high power to avoid any unwanted movement of the nucleus. Now we will talk about each parameter in order to have a groove without pushing the nucleus. Starting with irrigation. We need higher irrigation during sculpting than during pre-phaco to create a cooling current to decrease the high temperature produced by using high power. As we mentioned earlier, sculpting means high power. The aim of this cooling current is to protect the endothelium and the wound. So keep in mind that in addition to OVD, a cooling current is also a factor that protects the endothelium. Second aim of irrigation is to have a deep chamber so the heat will not be very close to the endothelium. Moving to the second parameter, which is aspiration flow rate. As we mentioned earlier, aspiration flow rate is responsible also for cooling current inside the eye, and also it aspirates any milky material during sculpting. So we need medium aspiration flow rate. Another very important point that I should stress on is to avoid full occlusion of phaco tip during sculpting. If we occlude the phaco tip during sculpting, this will prevent the creation of cooling current. So the ideal is to have only partial occlusion of phaco tip, which is 1/3 to 2/3, to allow the cooling current to be aspirated. Moving to the vacuum. Do we need to hold the nucleus during sculpting? Actually, we don't need to hold per se, but we need only to fix the nucleus in place and avoid any movement of the nucleus, which will stress the zonules. As we know that the power results in a repulsive movement of the nucleus, we need vacuum just to avoid the movement of the nucleus and fix the nucleus in place. So we need only low vacuum. Also, we need a vacuum since the machine pump will not work if we set the vacuum on 0. Moving to the fourth parameter, which is the power. As we mentioned earlier, sculpting equals to power.
If we don't have mature cataract, zonulopathy, or anterior capsule, or diseased endothelium, no need to start with very high power. It's preferred to start with reasonable power, then titrate accordingly. The best is to use continuous mode to have a smooth movement of phaco handpiece during this step. The movement of phaco handpiece with no movement of the nucleus is affected by several factors, as we mentioned in this equation. It's affected by the phaco power used, the speed of movement of phaco handpiece during sculpting by the surgeon, so he moves the handpiece slowly or very fast, and also by how much the surgeon engaged the phaco tip. As we mentioned earlier, we should engage it 1/3 to 2/3 only, not fully. Let's say we are dealing with a patient who has Fuchs dystrophy, so we don't want to use high power during sculpting. How to overcome this problem? So we can adjust the other two factors to achieve a perfect sculpting without moving the nucleus. Here we have two surgeons. The one on the left, he's engaging almost 2/3 of the phaco tip, and the one on the right, he's engaging only 1/3 of the phaco tip. If we follow the equation, the one on the right who engaged 1/3 of the phaco tip will have stronger sculpting power. So if we don't want to increase the power too much, we can engage only 1/3 of the phaco tip. So if we have such movement of the nucleus, it means insufficient power. Remember, the phaco handpiece should move during sculpting, but not the nucleus. To solve this problem, we can increase the phaco power and decrease the speed of handpiece movement and to engage less of phaco tip. So we have three options. Here also we can decrease the engaged phaco tip from 2/3 to 1/3 and decrease the speed or increase the power. Sometimes we will have excessive power during sculpting, which also are very risky because you might all of a sudden reach and open the posterior capsule. So here during sculpting, we reached here a very deep groove, which is risky because we are close to the posterior capsule. I made this animation as a summary of what I have mentioned about sculpting. Please notice that the movement of the phaco handpiece should be curved to follow the curvature of the posterior capsule. To sum up, aspiration is needed for cooling to overcome the high power used and for aspiration of milky materials. Vacuum is needed for the pump to work and balance the repulsive power movement and to fix the nucleus in place. The power mode, we prefer to use the continuous mode, not burst or pulse mode. The third step is the quadrant. Our aim of the quadrant is to have a good flowability, which is controlled by aspiration flow rate, and to have good holdability, which is the function of the vacuum. Also, our aim to have enough power to emulsify the nucleus, but with minimum damage to the corneal endothelium, and to have a balance between the attractive and repulsive forces to avoid shattering. The fifth aim is to have a stable and deep anterior chamber and to avoid post-occlusion surge. So we have to achieve a balance between the inflow and outflow. So aspiration should be fixed but not linear to avoid turbulence. Also, we need a cooling current since we will use a high power during this step. So the sequence of parameters adjustment, we need high power. High power can result in two things: in heat production and repulsive movement. So the vacuum and aspiration flow rate should be also set on high to attract the nucleus and to overcome the repulsive forces. Irrigation should be also high for three reasons. First is for cooling, since we will use high power. Second is to avoid surge, since we will use a high aspiration flow rate. So we will have excessive outflow, so we have to increase the inflow. The third is to have a deep formed chamber and to push the posterior capsule away from the phaco handpiece. In the following slides, I will be discussing 9 problems that can be faced during this step and how to solve it or how can we prevent it. First is the shallow anterior chamber. If we have shallow anterior chamber during phacoemulsification, we can deepen the chamber by increasing the bottle height or by decreasing the aspiration flow rate. If the repulsive forces is much higher than the attractive forces, in another word, excessive repulsive forces or insufficient proximal flowability, we will have shattering. We can solve the problem of shattering by increasing the attractive forces, by increasing the aspiration flow rate and vacuum, or by decreasing the repulsive forces, by decreasing the power, or by changing the module from continuous to pulse or burst. Because in pulse and burst we have off time, which allows the attractive forces to rehold the nucleus, or by changing the movement of phacotip from longitudinal to torsional or ellipsoid based on the machine you are using. Keep in mind that repulsive forces of ultrasound is more when the phacotip moves forward and backward like in longitudinal than if it's moving from side to side like in torsional or ellipsoid. The fourth problem is the nucleus tumbling, which occurs during last piece removal. Tumbling is very dangerous if we are dealing with a dense cataract with very sharp edge. As we can see here, because of high aspiration flow rate, the sharp edge of the nucleus can cause BC tear while the handpiece is very far from the posterior capsule. To avoid tumbling, don't use very high aspiration like 45 or by positive control. Positive control means that you don't want for the last piece to come to the handpiece, but instead go close to it without aspiration in step 1. Then start step 2 once you are very close to the last piece. The fifth problem is poor flowability. Just to remind you, the flowability means how fast the nucleus pieces moves toward the phacotip. And as we mentioned earlier, the flowability is the function of aspiration flow rate. And also, please remember that if the bottle height or the irrigation excessively higher than the aspiration flow rate, the flowability also will be less. If the nucleus pieces are not coming toward the phaco handpiece or coming very slowly, we can do the following. Increase the aspiration flow rate. But if we increase the aspiration flow rate, which controls the outflow, we have to increase the inflow, which is the bottle height, to deepen the chamber and to make it stable. But before we do that, we have to check for BCR or any vitreous in the anterior chamber, since poor flowability is one sign of BCR and vitreous prolapse. Another thing that we should check for is the bottle height. Maybe it is excessively high. For example, if the bottle height is 120 and the aspiration is only 15, for sure the flowability will be compromised. The third thing, we have to make sure that we have complete fracture of the nucleus. And the last thing is to check the aspiration tube leakage. Another problem which can increase the risk of BCR is a high vacuum during last piece removal. During last piece removal, we have to work carefully when we are using the vacuum or to lower the vacuum during last piece removal. Problem number 7 is poor holdability. As we mentioned earlier, holdability is a function of the vacuum. Once the surgeon encountered poor holdability, he or she should first ask the assistant or the scrub nurse to check the machine screen. If the machine reaching maximum vacuum. So if we are reaching maximum vacuum but still the holdability is poor, this means that the vacuum level should be increased because it is insufficient. But if we are not reaching the maximum vacuum, 3 things must be taken in consideration. First is to wait for vacuum rise time or increase aspiration flow rate. And if we increase the aspiration flow rate, don't forget to increase the bottle height as well. Second is to manipulate the nucleus to cover the whole tip to have full occlusion, because the vacuum in peristaltic pump will not reach maximum preset level unless there is full occlusion. Third is to change the power mode to burst mode, which have less shattering and less repulsive force. Post-occlusion surge. This is a very dangerous. I made this cartoon just to show you the surge and the risk of BCR during surge. because the bag will come toward the phaco handpiece and also result in endothelial damage. Please note that the sudden collapse of the AC and momentary pupillary constriction. Surge occurs due to several factors. Some factors related to the phaco machine itself and cannot be corrected during the surgery, and some factors related to the fluidics, in which the inflow is much less than the outflow immediately after emulsifying the nucleus. So that's why we called it post-occlusion surge. If the inflow, in which the irrigation is low, or the outflow is high, surge will occur. So we have to reach a balance between inflow and outflow to avoid surge and its related complications by increasing the irrigation or decreasing aspiration and vacuum. Also, if the cause is excessive wound leak, for example from the paracentesis, surgeon can place a suture and make a new paracentesis, or by removal of the second instrument if the surgery allows. The last problem is wound burn, which is due to excessive heat generation because of high power or caramelization of the OVD, or tight wound or low cooling current. Very tight wound can decrease the actual irrigation because it squeezes the irrigation flow, so this will make a low cooling current. Epinucleus is one of our friends during phacoemulsification because it keeps the posterior capsule away from the phaco tip. Epinucleus is not that hard, so we don't need much of power. We need only medium to low power and sometimes no power. When we talk about the vacuum and aspiration flow rate, it should be set on medium because high aspiration flow rate or vacuum can eat the epinucleus piece in place, which might result in PCR because we don't have any protection behind the epinucleus. So the aim is to have a medium aspiration flow rate and vacuum only to hold the epinucleus and move it to a safe pupillary plane, then eat it there. Since the outflow is on medium level and no much of heat produced during this step, irrigation can be set also on medium. Cortical removal step. In this step we used IA handpiece, which doesn't have power, so we have only two steps on phaco pedal. Step 1 for irrigation and step 2 for aspiration flow rate and vacuum. But if we worked on continuous irrigation on, we will have only one step, which is aspiration flow rate and vacuum. Back to the parameters, aspiration should be also low to medium, vacuum should be high and linear, high because of the tip is not sharp, linear because there is no protection to the posterior capsule by IOL or epinucleus polishing. During polishing, all parameters should be low to medium and linear. In this step, we will remove only very scanty cortical material. OVD removal. Now we have IOL in place, which works as a barrier between IA tip and posterior capsule. Because of this protection, we can increase the aspiration and vacuum for fast OVD removal. Irrigation should be medium to high, also to keep the chamber formed and to facilitate the flowing of OVD toward phaco tip. The last point in this presentation is the anterovitrectomy. Surgeons should do anterovitrectomy and avoid any traction on the vitreous, because this traction of the vitreous will cause a traction on peripheral retina, which might result in retinal breaks. The second aim is to avoid excessive hydration of the vitreous. So avoid pointing the irrigation board toward the vitreous and BCR, which can result in BCR enlargement. So you will start with the small BCR, and after improper anterovitrectomy, the surgery will end up with large BCR. We have two modes for anterovitrectomy. Step 1 is always for irrigation in the foot pedal. And step 2 and step 3, we have two options. We can make the step 2 for cutting and third step for aspiration flow rate and vacuum, and we call this mode cut IA. So we'll start by cutting, then aspirating. The other option is to keep second step for aspiration flow rate and the third step for cutting, and we call this mode IA cut. We use cut IA, which is the first mode, to cut the vitreous, because if we start with cut, this will not cause any traction on the vitreous. Whereas if we do anterior vitrectomy using the second mode, which is IA cut, this will cause significant traction because we are aspirating and vacuuming the vitreous, then cut it. But in reality, we need to cut, then aspirate. Also, another point, when we cut the vitreous, then we want to move to another place to do further anterior vitrectomy, we have to move slowly while pressing on cutting on step 2 to cut any vitreous on our way. Regarding IA cut mode, it is used for nuclear, epinucleus, cortical, and OVD removal. If we use cut IA to remove the cortical, the cut will work first before the aspiration, and by this, the tip of the vitrectomy will cut the anterior capsule. So if we try to remove the cortex, we will cut the anterior capsule at that area if we use cut IA. But for cortical, we have to use IA, then cut. During anterior vitrectomy, we set the parameters on low, except the cutting rate. It should be on maximum to have efficient anterior vitrectomy. Also, this animation, I made it just to show you the difference between the two modes. This is bimanual anterior vitrectomy. We start with the irrigation, then start with cutting before even going inside the vitreous strands. Now this is IA cut. We will remove some of the cortex. In the following slides, you will have a recommended settings for different phaco machines.